Hello, everyone. Welcome, welcome, welcome. We'll get started in a couple of minutes. Just give some time for everyone to join. Right. Let's get started. So my name is Rebecca Penn, and I'm the project manager for the National Safer Supply Community of Practice. I live in the traditional unceded land of the Mi'kmaq people and in what is colonially known as Nova Scotia. And I work for London Intercommunity Health Centre in Ontario. So I'm really pleased to be here today to get our webinar going. It's the Parkdale Queen West Community Health Center team today presenting on the evaluation of their safer opioid supply program. So very excited to have our presenters with us today and very happy to have all of you joining us to hear about the results of this evaluation. Before we get started, I would like to begin by acknowledging colonialism in our past as well as in our present. We come together today from different places across Turtle Island as people who live on treaty lands and unceded territories. We work in a sector whose goal is to address social harms, and we must recognize that the production of these harms comes from the history of colonialism and its enduring practices, institutions, and ways of thinking. Colonialism is with us today, and we must commit to working in ways that reshape these institutions and practices to repair harms, to prevent future harms, and to work towards a more inclusive and just future. I'd also like to take a moment to acknowledge that our drug policies have a disproportionate impact on racialized people, including African, Caribbean, and Black communities, as well as women and members of our LGBTQ communities. Just like to take a moment to reflect. I'd invite you all to join me in taking a moment to reflect on the lives lost and the harms that have been caused by these drug policies and just reconfirm or reaffirm our commitment to addressing these. I'd also like to invite you to introduce yourselves in the chat. You might want to let us know who you are, where you're joining us from. It's great to learn about the traditional names of the regions that we're from, and it's nice to use that opportunity to share that knowledge with us in the chat there. So some of you are members of the National Safer Supply Community of Practice. Some of you are guests joining us today. So just very quickly about who we are and what we do. We are funded by Health Canada's Substance Use and Addictions Program, and we are a collaboration between the London Intercommunity Health Centre, the Canadian Association of People Who Use Drugs, and the Alliance for Healthier Communities. Our mandate is to support the scale up of prescribed safer supply programs across Canada. We also engage in many conversations about the importance of expanding the continuum of care for people who use drugs so that it is based on a harm reduction foundation and increasing the doors that are open to people who use drugs and the quality of care that people have access to. We also spend a lot of time talking about the need for drug policy reform and the expansion of models of safer supply to include community-based non-medical models. To find out more about what we do, please go and see our website. We'll post in the chat where our website is so that you can find out there. We have lots of great resources there. About today, we will be recording this event and we will share it on our website. Our website does have an archive of our past webinars. Feel free to go there and get not just the videos of the webinars, but also resources connected to those webinars. So this video of this webinar will be posted on our website along with the report that the presenters will be discussing today and other related materials. If you are having technical difficulties, your best bet is actually just to log off and then log back on again. And we do have closed captioning available in English. You can find the button for closed captioning at the bottom of your screen. I do invite you to use the chat if you'd like to make some comments or introduce yourself or share any resources, things like that. I'm really happy to have my team with me, my colleagues from our team with me today, Fola, Robin, and Alex, who will also be posting in the chat, sharing resources, certificates, and other things like that. We will be having a poll after the presentation and before the question and answer, and I'll ask you to please participate in that poll. It's really important for us. And if you do have questions that you'd like to put to the presenters, I invite you to put those in the question and answer box. And if you have any trouble finding those, just put a note in the chat and we'll make sure to direct you. So yes, we have a certificate of attendance available for you at about the halfway mark. Robin will put in the chat a link that you can click on that will take you to a form to fill out that will generate a attendance for you to have to say that you were at this webinar today. And just a quick shout out about an upcoming event on Wednesday, May the 17th. Katie and the National Safer Supply Community Practice are co-hosting a webinar about safer supply. We have Angela Robertson, Ashley Smoke, Corey Ranger, Jillian Cola, and Maria Goye coming to speak, bringing their perspectives about safer supply. And again, I invite you to check out our website where you'll find lots of resources, past webinars, and more information, including how to join the community of practice. And with that, I'm very happy to pass this over to the Parkdale Queen West Community Health Center team. I will say I've been particularly excited to see this evaluation report come out, and I'm really happy to be hearing about the findings today. I was first involved with the Parkdale Queen West Community Health Center team back in 2020 when the funding first started, and in preparing for this webinar, I was reflecting on just how much has been accomplished by the team, how much the team has developed, and it's just really exciting to hear about what's happening at Parkdale Queen West in Toronto. All right, Paul, I'll turn it over to you.
Hi, everyone. My name is Paul Colosimo. I'm a case manager in the Parkdale Queen West Community Health Center Safer Opioid Supply Program.
I'm Ashley Smoke. I'm part of the evaluation team at Parkdale Queen West Community Health Center.
And sorry, I was just fussing with my screen to get it to share properly. My name is Kate Atkinson, and I am the project manager in the SOS program at Parkdale Queen West.
Okay, so I'm just gonna get us started with a brief summary of our program's history. So primary care providers at Parkdale Queen West Community Health Center started offering safe opioid supply in 2019 under shared guidelines at that point in time. 2020 saw funding from Health Canada's Substance Use and Addictions Program alongside the Downtown East Collaborative SOS in Toronto, which then eventually moved to a supportive model led by a team of nurses and nurse practitioners who work full-time at each health center. The clinical teams provide consistent care and safe monitoring with long-term care planning suited to the unique needs of individuals receiving safe opioid supply. Parkdale Queen West Community Health Center worked from 2 base sites, with SOS programming stretching across both sites. possessing a team of 2 nurse practitioners, 4 registered nurses, and 2 case managers divided equally between sites. Counseling services are offered to the clients, with the counselor working across both sites, and a management team consisting of 1 supervisor, a project manager, and an SOS program manager. Our client advisory committee has 7 to 8 members who offer observations and suggestions for improvements of service provision. The committee is a collaboration of individuals currently accessing SOS services and members of the program's team. So as of this past December 31st, 2022, there was a total of 86 active clients receiving safer opioid supply at Parkdale Queen West Community Health Center. 40% were women, 53% were men, 7% were trans, non-binary, two-spirit identified, 22% were Indigenous, and 58% were white. Our SOS program has committed to using 4 objectives as a primary focus for our service provision, along with creating transparency with funders of our goals as a program. The first objective is to reduce the risk of overdose and deaths by providing adults exposed to the contaminated illegal drug supply with low barrier access to a safer drug supply. 2 is to respond quickly to the ongoing overdose crisis by implementing and evaluating a low barrier, community-based safer supply model that can be delivered by primary care providers with minimal resources. 3 is to engage participants who face barriers to accessing traditional models of primary care and harm reduction, stabilizing healthcare, and comprehensive care services. And 4 is to reduce harms associated with illegal activities required to access drugs through the illicit market.
To carry out the evaluation, we used a few different tools. We conducted a baseline survey with people who had started in the program within the last 4 weeks, and there was a relatively small response rate, as you can see from here. But it does represent about a third of the clients who joined the program last year. And then there was an ongoing care survey, and that was given to anybody who had been in the program for at least six months. And there was a little bit higher response rate in that group, about a third of the active clients at that time. And then I also carried out 15 more in-depth interviews with clients, including making sure that there was robust representation of women and non-binary, trans, and Indigenous clients, so that comes through well, like those experiences come through well in the data. And then finally, there's the electronic medical record, just to get some program statistics. Okay, so Paul just had talked about a second ago about those kind of 4 objectives. And those objectives were things that we put forward in the pilot version of the program, objectives that we wanted to meet. And so they form the kind of backbone of the evaluation. They form the framework that we asked, of the questions that we asked. So to start with, we looked at the reduction in risk of overdose and deaths, providing access to a safer drug supply. And this client in their interview said, when I started the program, I was on fentanyl, a lot of fentanyl, and I was at the point of overdosing all the time. I didn't want to die. So they offered me the program and I went, yes. She said, you're a candidate, would you like to? And I started to cry. I needed something to keep me alive. I started the program there. And this quotation reflects the experience of many clients who are coming into the program, who are really looking for something that will support them and give them an option to keep themselves alive. So we did find people do feel that the Safer Opioid Supply Program is reducing their risk of overdose. Some people talked about not having had overdoses since being on the program. And then also participants talked about having had a history of traumatic overdoses. With the unwanted benzos in the supply, people are having very drawn out overdoses, things that haven't been typical of opioid overdoses in the past, things like seizures, experiences of blackout, amnesia, sometimes for hours or days at a time. And then also participants spoke to the experience of having to revive a partner. And all of this is extremely traumatic for people in the program, of course. And so to have their risk of overdose alleviated has huge mental benefits as well, huge stress benefits. Importantly, people felt that their risk decreased even if they were still using fentanyl. And this had was partly to do with the fact that when people have a reliable access to a known supply, that can support less risky use patterns. So people talk, for example, about not feeling like they need to use everything they have, like all the fentanyl they have all at once, because they know that there's like a daily supply of opioids that they have secure access to. And then among people who prefer to use alone, people did talk about how it felt safer to use alone now because the substance that they're using is a known makeup and quantity. So if we look at people's reported experience of overdose in the baseline group, in the people who started in the program in the last 4 weeks, about 50% said that they'd had an overdose in the last 3 months. And that makes sense because one of the things that we look at when people are coming into the program and being taken in is whether they've had a recent experience or history of overdose. And then if we look in the ongoing care group, people who had been in the program for 6 months or more, only 15% of those people reported having had an overdose in the last 3 months. So we do see the program having an impact for people, importantly. People also talked about having changing patterns of use. So among people who they had a goal around using needles less, some people were moving away from that because the safer supply that we give in the program, for anybody who's watching from outside of Ontario, our options on the Ontario drug formulary are somewhat limited. Mostly what we have access to is tablet hydromorphone. And so people in the program, their safer supply looks like tablet hydromorphone. And you may see in a couple of the quotations, people referring to the brand name of Dilaudid, which is what everybody prefers. So because tablet hydromorphone can be injected, it can also be taken orally. There's some people who find that they're decreasing their use of needles, which if that is a goal for somebody, then it can have positive health implications in terms of decreasing the risk of some kinds of infections and things. And then others talked about having slowed down or stopped fentanyl altogether. And importantly, some people in the program, and certainly not everybody, and we'll talk about this later, found hydromorphone to be acceptable for them. So if you look at the chart on the right-hand side, which you probably already have, 26% of people said that they had decreased the overall amount of fentanyl that they were using since starting safer supply, and a full 52% said that they had actually stopped using street fentanyl. People also talked about how being in the safer supply program was having a positive impact for them in terms of decreasing withdrawal, dope sickness, and pain. So some people found that they had at least diminished dope sickness and withdrawal. And in some cases, maybe no withdrawal or no dope sickness. People talked about having managed pain and having just, I referred to this a little bit before, just the reduced anxiety around how and when they're going to be able to get opioids. But importantly, what we can provide in the Safer Opioid Supply Program, we heard loud and clear that the options that are available are insufficient for people to fully quit fentanyl or fully quit, regulated or unregulated fentanyl as they would want to. So you can see a quotation that's talking about that at the bottom of this slide, saying it just doesn't cut it. I'm still using, not as much, but I am still using. And so actually 92% of clients on their survey said that the way they use opioids on Safer Opioid Supply causes fewer or better side effects than before they were in the program. So looking at objectives 2 and 3, which has to do with healthcare access, including primary care, we see this participant saying, but here I feel like more than my health within the SOS program with the Dilaudid and Cadians. Cadians is another of the medications people often take. Even more stuff like my mental health stuff is being looked into and after. And even if I have a cut or something on my arm, I feel like I can come here and talk to my nurse practitioner about it. So certainly people talked about having greater access to support for both chronic and acute issues, everything from Hep C, STIs, x-rays, infections, getting referred out to specialists, all kinds of things, dental issues. And something that several clients really, well, I would say most clients underlined in our conversations is how it means something to people to have a foundation of a trusting relationship with their provider. And that's really what enables people to access all of these additional health supports. Without having that trusting relationship, then that isn't possible. And for so many people, they've experienced horrible discrimination in healthcare and haven't been able to address some of the health issues that they need to. But in the Safer Supply program, there's lots of really positive relationships that are allowing them to have that health access. And then providers in the program are also providing substance-related knowledge that then people can take and share with their peers, share with community to help with safer use and avoiding infection and things like that. So when we looked at when we asked people in this small baseline cohort whether they have an issue, a health issue that they haven't been able to work on, 33% of people said that, yeah, I think I have a health issue I haven't had a chance to work on. But in the ongoing care group, asking if anybody has addressed a health issue for the first time since they started Safer Supply, 73% of people said that yes, they had. So certainly people's health access is shooting up, being a member of the SOS program. Access to hospital care, we know that and heard in the course of these conversations that discrimination continues in hospitals and negatively impacts people's experiences. Some people, few people are being continued on their Safer Supply prescriptions when they're in the ER or when they're admitted to the hospital. However, there are a couple of glimmers that a couple of participants talked about having been continued or having health providers in the hospital understand a little bit more about Safer Supply. So we hope that with advocacy, maybe the tide will turn. This person's talked about having been not continued on their Safer Supply. They said that they would have wanted to be, and they asked about it. And the question I got back was, how did you manage to talk to a doctor into giving you so many Dilaudids? I mentioned the Safer Supply program, and that seemed to be the end of that. And then in terms of decreased involvement in and harm from criminalized activities, this participant said, what's working really well about the program, honestly, not being sick every morning and taking that drive away from always being on the hunt for fentanyl and always worrying about where your next fix is. And some of the activities that are involved in getting that have ceased, which has made stress levels go way down and safety risks for myself and other community members go way down as well. So in conversation, people talked about this double vulnerability when it comes to police, because people are prosecuted by the police, but then when their rights are violated, they're not protected by police either. People did talk about having been able to decrease or stop or slow down street-based criminalized activities being in the Safer Supply program. And among people who talked about being able to decrease or stop street-based sex work, that was an important safety factor for them, feeling more safe because of that. So in survey results, we can see on the left there of this chart that 27% of people felt that their police interactions had decreased since starting in Safer Supply. Some people you can see had no police interactions, and the pink bar there is people didn't feel that their police interactions had changed in any way related to being in the Safer Supply program. Okay, so those were kind of the primary outcomes. So those speak directly to the 4 objectives that we talked about off the top, but there's a whole series of secondary outcomes to get into here in terms of how being in the Safer Opioid Supply program has an impact on people's access to social care as well as quality of life. And even though those first 4 objectives are kind of core to the initial the pilot phase and the funding of the program, this integration of social care with the healthcare is fundamental to the way the program is built. So this person says they take the time to get to know you. I had the 3 people before I got to get any prescription, and that was good. They asked all the right questions, and it's not here, fill out this form. Here they get to know you, which is really great to hear, because that's the hope, that's the objective, I think. So participants did talk about how this integration of healthcare with the social care, so namely case management and counseling, we have the role, as Paul explained, of case managers as well as a counselor in the program that's just dedicated to SOS. That's really important to people and is having an impact. People also talked about, being able to see a case manager and then walk down the hall and see their nurse for their clinical appointment as well. So having this kind of same day health and social care is very supportive. And then people have access to a wide variety, a big range of case management supports, which supports the well-being that they're achieving through the health access as well. Counseling is something that we added to the model in 2022, having a full-time counselor start in the SOS program, and it's clear that it's offering huge benefits to clients. The counselor, from what people said in these conversations, the counselor is sort of perceived as separate from the information giving roles of the clinicians and the case managers. So someone who truly kind of just doesn't have as many maybe tasks in mind, but is there as a support. And it's clear from what people said in these conversations that there's a need to continue to support clients to connect with both the SOS counselor, but also with counselors maybe in the rest of the health center or in the community, if people are continuing to look for a fit. Or, for example, someone mentioned, because of their community role, they'd rather seek counseling outside of the health center. And so we'll continue to make those referrals as needed, but certainly the embedded counselor is a real positive for people. So this person says, I'd say the counseling, when you use the counseling for what it's there for and take advantage of it, that would be the best part of SOS. It's just made it feel that I'm getting listened more to, and I'm guessing other clients are getting listened more of their concerns and observation towards what's working and what's not working. At baseline, 40% of people said that they had worked with a case manager, housing worker, outreach worker, or counselor. And then among the ongoing care group that we talked to, 89% said that they worked with a case manager. So people's access really has increased a good deal. Okay, and I'm going to flip it to Paul for a second to talk a little bit about how housing supports work.
So in accessing SOS programs, service users have been able to work with case managers to develop independent living skills associated to housing stability. Many clients accessing SOS have been able to secure housing, which has further created more space for individuals to focus on their own physical, mental, and emotional health while engaging with SOS care plans. After transitioning from street homelessness to housed, individuals can develop skills in housing retention and eviction prevention. This can range from making sure their rent is paid on time, work on unit upkeep and maintenance, as well as developing skills around enhancing communications with landlords and being informed of your legal rights as a tenant.
So people did talk about housing, and at least one participant pointed out that, housing is a structural issue that can't be fully addressed can't even be can be maybe partly, but it really needs to be addressed at higher levels. But the very encouraging thing is that many clients do associate getting housing with being in the program. and pointed to the fact that new housing is a foundation, which Paul was talking about too, from which other desired life changes are possible. And some are associating retention of their existing housing, like maybe they came to the program already having housing, but retaining that is also associated with being in the program, which is also important. This person said, when I met the case manager, I was on a bench this summer. I was the last 8-10 years. I've been every winter out on the street except for the last 2. Since I met her was the last winter I spent on the street. So I think it's fantastic. It's amazing. When we talked to people, did the surveys about housing supports, you know, even considering the housing affordability crisis in Toronto, 27% of clients surveyed reported getting housing because of being in the Safer Opioid Supply program, which I think speaks to what Paul was saying about those very intentional and consistent supports being provided by case management. However, 54% of people still continue to require new housing, so this needs to be maintained as a focus and ongoing effort in the program. Okay, so people also talked about improved quality of life. This person said, I know I don't have to go sick. I know my Dilaudid's are there. I know I don't have to be in pain. I have that choice to use fentanyl if I want to, or if I don't want to. And it makes it safe for the community. So this quotation to me just speaks of like some of that stress being relieved for people, of not having that constant anxiety about feeling terrible and being in pain and not knowing how relief will come. This person talked about having gotten a job, stable housing, stopping using, connecting with kids again, being in school. So one of the areas that people talked about in terms of improved quality of life is in relationships and work. So people talked about having improved relationships with family, including pets, and being able to plan more freely, being supportive to relationships. So the model of our Safer Supply program is daily dispense, which means that people go to the pharmacy once a day to pick up their medications, and then they can go and use their medications throughout the day, however they decide. So it still requires, you know, a daily visit, but outside of that, people have the freedom, the autonomy to decide, you know, how and when they want to use their medication. And what that means is that when there are people in clients' lives who aren't safe, it's not safe for them to know about the person's drug use. This facilitated some relationships and also work for people. For example, if a boss, if it's important that a boss doesn't know because of stigma, discrimination, then there's some choice around that. And then for this reason, also some people were able to take more hours at work. There's also the psychological and the mental health factors for people. So again, this ongoing theme of the decreased stress, better managed pain. People also talked about having better sleeps, more routine, and even feeling less lonely because there's a trusted person to talk about substance use with, and to really make plans around that in a way that's not judgmental. And then also, I think people just talked about having sort of a future orientation because of being in the Safer Opioid Supply program. So setting future goals, wanting to live longer, and then in general, having decreased fear, and then having also some more free time. On the ongoing care survey, we asked about some of these quality of life improvements, and you can see people, the vast majority of people agreed that other things in their life have improved. They have a greater sense of safety, more money to do things they want to do, more time, and being more connected to healthcare. And nobody said that being on Safer Supply has not really improved things. You'll notice that of all of those, though, the lowest percent agreeing is having more money to do things that people want to do. A lot of the majority of the people in the Safer Opioid Supply program are on some form of social assistance, and we know that social assistance rates are make it very difficult to live, even with the relief of not having to spend money on obtaining fentanyl. It still is hard for people. So access to harm reduction supports and programming was another theme that came through in these conversations. I love what this person said, just defining harm reduction for them. It feels to me like a beautiful definition. Harm reduction is pretty much the allowance of a human being to use their drugs in a safe way and a safe space, and to give them all the correct information and knowledge to allow them to consume and use what they want, how they want, when they want, in the safest way possible, for them to get the safer supply if possible to use that drug. We do at the health center have a lot of harm reduction programming that's embedded at both of the main locations here. So it's not terribly surprising that 61% of clients said that they already had good access to sterile equipment. There are harm reduction rooms at both locations. We also have supervised consumption services, drug checking, again, all kinds of harm reduction gear, and then also harm reduction education. However, 30% of clients said that their access to sterile equipment increased because of being in the SOS program as well. And again, Paul, I think he'll speak to some of the other aspects here.
Yeah, close collaborations between SOS programs and safe consumption sites have resulted in extending the positive impacts harm reduction has in destigmatizing substance use while providing safe, judgment-free spaces for individuals accessing care at Parkdale Queen West Health Centers. This collaborative approach can continue to work with individuals on increasing visits to the health centers and enhance engagement with their supportive care teams, providing space to focus on unique physical and mental health challenges while simultaneously addressing areas of their own social isolation while developing skills and autonomy of how to navigate systemic barriers.
Ashley, did you want to add anything at this point, or are you good for now?
I'm good for now.
Okay. In terms of safety, this participant is a woman. She said, "You stopped letting those men take advantage of you in the program when you guys gave us the Dilaudid. We stopped doing that, and we stopped doing all those things, and we believed there was hope. For me, I believed there was hope. So I stopped giving them the power of controlling me." And this came through really strongly in the conversations that for women, the SOS program is having a profound impact in terms of safety. People talked about having a decreased need to go out at night, not needing to go to dealers who don't feel safe, not needing to depend on other people for cash, being able to having a greater ability to avoid sexual assault while intoxicated. This is partly because, you know, as I mentioned, overdoses with the benzos and other substances like xylazine in the supply mean that overdoses can be lengthy and can involve really sort of blacking out, and that makes people can make people quite vulnerable to assault. And so being able to avoid that, and then in general having greater autonomy for men. So for women, the SOS program is having this kind of providing both sort of social and bodily autonomy. We did want to check in with people about cultural safety as well, aside from just physical safety. So I did ask Indigenous participants, women and non-binary or trans participants, about whether they felt they were receiving appropriate care and supports, and no urgent issues around cultural safety were brought forward. However, you know, it's important for the program to continue to connect Indigenous clients, for example, with we're so lucky here at the health center to have an Indigenous health and wellness program called Ni Win Win Danamak, and that's Indigenous run and staffed and led. So, it remains important to build those bridges between the programs to ensure greater cultural safety. 92% of clients said that the way they use opioids while on SOS feels safer for them than before. Okay, so the last couple of sections that we'll talk about, this one's really important. Client identified needs are some of the main themes that came forward from clients in terms of what more is needed beyond this point, because I would say that two things were true at the same time. Clients talked about how the program is life-saving, life-changing, extremely beneficial, and then also that we need to do better in terms of, for example, what substances we're able to provide people. So this goes to the first need that was identified and articulated by people. There's a desire for a greater range of options related to use and treatment. So around use, some people want to use heroin, some want to use like regulated fentanyl of a known kind of quantity. Some are fine with the hydromorphone, which I mentioned at the beginning, but people also want smokable and injectable options. So generally, we just have a lot of work to do in terms of what's available. People also want smoking in inhalation spaces. There's only currently one, I believe, in Toronto right now. So that's a huge need in the community because lots of people do smoke. And also, a couple of people talked about wanting to go to treatment, but treatment doesn't continue safer supply. So that's a huge barrier for people. So there's a need to work on that and make it possible for people to be continued on safer supply in that setting. Program members also talked about wanting to access multi-day carries. As I mentioned, carries being take-home doses. As I mentioned, we have a daily dispense model where people take away their medication for one day at a time. But and that does bring with it some autonomy because of not having to visit the pharmacy every single time you want to take a dose or visit a health setting every time you want to take a dose. But understandably, people are looking for greater autonomy through having access to multi-day carries. There's also a desire among program members for sustained funding and increased program capacity. People did talk about having lost loved ones and wondering whether the program could have been supportive for them, could have saved their lives. And there remains, and people talked about how there remains a great need in the community. And so wanting to see the program continue and grow and be able to offer care to more people. And then also just wanting to have work and volunteer opportunities, either in the program or in the community, among people who aren't already working or volunteering. Many articulated this, that they just want some of these chances to engage and use their knowledge. On the subject of these multi-day take-home doses, this person said, I never get downtime. I'm always working. And I don't mind, but after a while I burn out sometimes. When you have to go to the pharmacy every single time, people start to realize why you're going. And then I have to live in that neighborhood. That's probably what it is, the stigma around it. It's right up the street from where I stay, right? So of course people are going to notice. So that's just one of the reasons that someone might want a chance to have a multi-day take-home dose. And this SOS participant said, if they were to just take away the funding one day because so much misinformation has won, it terrifies me. That's a part of the nightmares that terrifies me, because I don't know, they would have a shitstorm on them. The city would explode. It would be dangerous. It would be killing people if they were to take it away. So there is a good deal of anxiety and fear among program members about the future of the program and making sure that there's sustainable funding in place. Okay, and then finally, we have some recommendations coming out of the evaluation. I won't dwell on this slide too much because there's a lot of text. I think these are all the recommendations, and these are in the report as well. So You know, all of everything that we've talked about today, you can read in a little bit more detail, and there's even more stuff in there in the report. However, this first point here, exploring options for providing safer heroin and fentanyl, that's just a response directly to that that first client identified need. That's something that we can work on in the program. And then some of the other points here are about continuing to connect people with the services that they need, continuing to provide housing support, things like that. But then we have recommendations at the community level as well. So we have them at the program level, the community level, and in a second, I'll show you the policy level. At the community level, one of the recommendations is to contribute to sector-wide protocols and resources for multi-day take-home doses and safer supply programs. And I think this conversation is very much alive right now in the community about multi-day take-home doses. So just continuing to participate in that and figure out what's going to work within this, you know, medicalized or prescribed model of safer supply. And then also working with partners to provide greater education to hospitals and treatment centers about the benefits of safer supply, so that people aren't taken off their safer supply when they're in institutional settings, right? So that safer supply is continued. And finally, at the policy and system level, we need to expand the opioids offered on the Ontario Drug Formulary to provide more options for prescribed safer supply. We need to develop and support non-medicalized models of safer supply. One thing that came through, I didn't really touch on this before, but one thing that came through is people talk about, you know, this isn't the only substance I use. I'd like to be able to get, you know, a known and pure version of, you know, this other substance that I take as well, you know. So there's a need for much more than what we have at the moment. Address the housing affordability crisis at all levels of government. And then also finally to decriminalize drugs and regulate the supply so that people aren't put in this horrible position of needing to use a supply that's lethal to them. So those are the recommendations, and I'm going to hand it over now to Ashley for some further thoughts, extending our conversation.
Yeah, and in terms of decrim, I really feel like it should also be not constricted by like amounts. Like I know in BC that their like threshold is 2.5 grams, and like people don't buy 2.5 grams of drugs, they buy 3.5 grams of drugs. Like everyone knows this, but they do it purposefully so they can recriminalize us. So I think we need to have people who use drugs be part of that conversation a lot more, and actually be heard on that. And then, so in terms of like harm reduction programming and these kinds of programming, it's so important to have like really good relationships. And like, so you don't know that like when you go to work that day, what kind of impact you're going to have on that person who uses drugs, and how your job is going to then impact their lives outside of the service. But your interactions, like having that rapport will help impact people who use drugs. And it could be like good or bad. You could play a pivotal role in a person's life, or you could be like the person who ruins healthcare for them. So it's really important and it's a big responsibility to be non-judgmental and help improve the lives of people who use drugs by taking it slow and having like reciprocal relationships, because that way you can really change someone's life and improve their health just by being there and sticking with them through all those things. And then we all know safer supply is life-saving, but it helps folks get their lives figured out. And I think we focus a lot on the life-saving aspects, but there's so many more things that happen in a person who uses drugs lives once they're on safer supply. It helps them not have to be dependent on the street supply, which is amazing, because like the benzos are really bad right now. It helps people keep their tolerance at a certain level and helps them gauge their use and taper their drug use on their own. It also helps them stop using, and they can use, or those who stop using and use occasionally overdose, and they risk death. So it not only reduces the risk of overdose, but it also improves the well-being of the person who's on the program. It's important that we expand safer supply and like use it as much as we can in the community. It access to a healthcare provider, it also increases all areas of health in their life, like their quality of life. But like, it's so important to have like wraparound care too, and like warm referrals, like Kate mentioned, counseling. I used to have counseling at a program, and then they decided to take it away just because of like financial reasons, and it disrupted my whole life. And like if I wasn't in the position I was, I would have definitely like spiraled. But I think like we don't understand what kind of impact those financial decisions have on the people who are attending the service. So I just wanted to mention that. Parkdale Queen West has a counselor, but they're so busy, and I feel like there's such a need. So expanding like that aspect and like case management, I think, is really important for next steps. We also, I noticed that at Parkdale Queen West, they go above and beyond to get you like the care you need, no matter where it is or what it happens to be. And they ensure that clients are like supported in all areas of their life. And that holistic approach, I think, is why the program is so successful. And the case management, they work like in a variety of areas. There's a specialized one for like people who have CAS involvement or court involvement. So I think like having those other parts in the community health center and having all those programs and services accessible to the safer supply clients is really beneficial. What needs to be improved though, I think, is like transitions for people in and out of the hospital. I know like for me, it's not easy getting admitted to the hospital. So trying to make those transitions more seamless, because we like have a lot of health issues and we often like go to the hospital for so many things. So yeah, it's nice to have like more protocols around that maybe. And then people who use drugs are often criminalized. So when you don't have to pay for your drugs, it's frees up your time to like improve your life, and it also improves your like self-esteem, and it enhances your life so you can focus on like freeing up time to make more things happen, I guess. And it also reduces the level of interference by the systems that can be involved. And it allows someone to focus on their social determinants of health and all the things that contributed to their drug use in the first place. So that allows people who use drugs to achieve like long-term goals, and it helps them create the lives that they want to live, not the lives that they have to live. So we need like all different kind of models moving forward. I think medicalized models are really needed because people on ODSP benefit from having a medicalized model, but people who make a lot of money might benefit from like a buyer's club or compassion club. So I noticed there's one organization I've met, and they have like a buyer's club and an exemption so that they can hold people's drugs for them in the service, and they can like kind of give them to them as needed, and they all pitch in and buy their drugs together. So I don't know, I think there's ways that we can do different models and work with people who use drugs who are already doing these kinds of things and kind of refer people who maybe don't benefit from medicalized model to these other different organizations or different clubs. Yeah, just like working with people who use drugs to work on what these models should look like. I think we should need to expand the medications. We've already talked about that, but so many people here are on meth, so they really like are looking for a safer supply option that's like gonna cut it for them, and they haven't found one. So I think just like thinking about other people's needs besides just opioids. And yeah, like there's groups like the National Safer Supply Community of Practice and Parkdale Queen West who have like advisories. And I know that they're interested in doing a lot of like advocacy or something like, you know, like community-based education and knowledge translation around safer supplies. So I think working with people who use drugs and those advisories and like bolstering and supporting the work that they do is really important in moving safer supply forward in the future. So yeah, thank you.
Thanks, Ashley. So before we move to a Q&A, and I'm anticipating, since we're almost at, we do have until 4:30, but we're almost at 4, so we may lose a few people, but don't leave yet, because we really, I think Rebecca is going to put a quick plug in for doing a little poll to get some feedback. But quickly, just want to say thank you to the National Safer Supply Community of Practice, all the client participants in the evaluation, program partners, the Evaluation Advisory Committee, and also Dr. Jillian Kola, who advised on the evaluation as well. We are supported by SUAP, but the things we've said aren't necessarily the views of SUAP, of Health Canada. And Rebecca, would you mind jumping in just around the poll?
Yeah, we're just going to launch a quick poll, and that helps both the National Safer Supply Community of Practice and Parkdale Queen West get some stats around who's here today and how this has been beneficial for you, and also what else we can do to support you and provide some good information to everyone. So if you could just take a minute to do that. I'll also invite you to put any questions that you have in the question and answer. I myself am brimming with thoughts and ideas based on all the things that have been said, but we do have a number of questions in the question and answer chat box or question and answer box. Shall I get started with that, Kate and Paul and Ashley? Yeah. Okay. I think I'll start with, there was a couple of questions about methodology stuff, particularly around your sample size and things. Can you remind us all again about what the sample size was for your surveys?
Yeah, so as I mentioned at the beginning, we had a small sample of the baseline folks, just 10 respondents, and then for the ongoing care surveys, it was 27 respondents, and the qualitative data came from 15 interviews.
Okay. Thank you. I think I'll also just remind folks here that we are looking at a program evaluation and with the goal of informing how the program is meeting its own internal goals, and how to improve care and things like that. So just thinking about the scope of what a program evaluation is compared to like a evaluation research study. There's another question here about the objectives. So the objectives I understood came from the original proposal for that you put for the program, the pilot project objectives for the funder. The question is about how the objectives for the evaluation were determined, and did it come from clients, or how did that happen? Yeah, do you want to speak to that, Kate? Can you speak to that?
Well, the evaluation objectives, as I said, so the question is about how the evaluation questions were formed?
How were the objectives, or how were the objectives developed? Yeah, did it initiate with the clients?
Well, the initial objectives for the project, I wasn't a member of the project at that early stage, but I believe there was, Rebecca, I know you were there for part of that. I believe there was community consultation around what the needs for safer supply were. And so that's how the model was initially developed. But then because we wanted to be able to check in directly on, whether we're fulfilling the objectives as we had laid them out, we started from those 4 and then built on top of that to look at other quality of life factors. One of the things, when you're designing the evaluation questions is I've had the chance to work over the last year receiving input directly from the client advisory committee. And so a lot of these issues that we touched on were things that were coming up a lot in those conversations and that felt like important things to look at from the client's perspectives.
And another question that goes with it is the barriers for participating in the surveys and such. Do you want to mention anything about how participation happened, or?
Yeah, I mean, for people who are participating as new members of the program, that there may be some barriers there if people don't have yet a trusting relationship in terms of completing some of those early surveys. And then for the ongoing care survey, we tried to reach as many people as we could and offer the opportunity. So we had posters up, we had outreach, we had convenience-based, when people were coming in for appointments, asking if people would be up for doing a survey as well. So that's how we got those respondents.
So there's another piece here, but I'm going to save it to the next question. One person is asking, do they need to have a goal to sign on to the program, or will one be worked upon with help if they don't have one? Just curious.
I'm going to throw this one to Paul and Mish as well, if they want to speak to this. And actually, Mish, if you do decide to speak up, if you wouldn't mind just introducing yourself as well.
Hey, I'm Mish. I'm a nurse practitioner and a clinical lead with the program. We don't require that people have a specific goal coming into the program, although most people are coming with at least the goal of reducing their reliance on the illicit supply. But we don't require that people are working specifically towards abstinence, and at times people's goals can also change. So at times people may want to be reducing, at other times, they're actually quite happy with the amount they're using. So all to say we don't have a requirement.
And speaking to the case management relationship, I think a lot of goals are uncovered as the relationship gets stronger with the supports. Like you first get connected and you're talking about, the safe opioid supply and your substance use goals. And then suddenly, you may want housing help. You may want to, go get your IDs together. Like there's a lot of little things that come with that relationship building aspect.
Yeah. And having a bit more time and feeling more connected in and trusting, all of that relationship stuff. Yeah.
Absolutely.
That's sort of a related question was around about mentioning further support for quitting is needed. What are those kinds of support needed? I'm going to answer that, even though if I can, because I think that question came in when you were talking about the people quitting fentanyl, like the use of unregulated street fentanyl. And to me, that was such a powerful statement or a piece around the need for other regulated drugs, other formulations, other types of opioids, including prescription regulated fentanyl. I hope that answers the question. Any other thoughts on that from the group?
I wondered if the question came also around people wanting to access inpatient treatment and continue with safe supply, because I think that could be a sort of complex situation to understand. A lot of people feel like inpatient treatment could help them with eliminating their fentanyl use, but they do want to continue with Dilaudid. Or often we're seeing folks who are working towards goals with other substances, whether that's alcohol, stimulants like crystal or crack, and wish to access programs for that, and feel that they're on a stable dose of safe supply and are happy with their opioid use. But getting access to treatment for the other substances is difficult when there's sort of like abstinence only approaches to care.
Thank you. Relating, I think that is, you know, one of the big pieces here is understanding that range of ways that people can use, and having the autonomy to choose how they want to use and such. So yeah, there's a couple of questions regarding, again, this expansion of options on the of medication options, and how do we get those? How do we get coverage on the formularies for ones that we can access? And if we can't access them, or sorry, yeah, if they're not even available, let alone to have put on the formulary, how do we get those? Do you want to speak to anything around that? Like, so one of the questions, just wondering what exactly would be involved in either procuring or ensuring that we could legally provide heroin or other options. How viable would it be to put a section for smokable, injectable safe sites?
Yeah, isn't that the question?
Yeah.
Is what I would say. I'm not a part of this. I think there's a lot of advocacy that happens, sort of out of the public sphere and in the public sphere, certainly, to try and expand what's offered. I don't know whether any of the other panelists have other insights to share about that, or even Ashley, I don't know whether you want to share even about advocacy that's like drug user led. Or
Honestly, Ontario is such an interesting place. I don't really know what it takes to get heroin here. We want it. I think that's where we could come in, like with organizations and people who know these things, and then we can work together to find the solutions. I know in BC, I think they're looking at making heroin. I don't really know though. I have no idea.
I think it comes
Buy it
down
on
to
the dark web.
yes, true. And there are, you know, in the buyers clubs, people are buying things on the dark web, testing them, and then distributing them. I think the issue of formulary or getting more options out there comes down to two things. One is under the medical model, something that is a medical product, so that's a drug that can actually be prescribed. So people can compound heroin, etc. The other half of the issue is getting funding for it. So, for example, there's a lot more access to other forms of fentanyl, like sufentanil or higher dose fentanyl patches in BC, and we could prescribe those here. They exist, but we just don't have the funding for them, and that's quite prohibitive.
Thank you. And along with that, you did mention around stimulant supply, stimulant safe supply. Is that also something that is in high demand at Parkdale Queen West?
go ahead, Mish.
I don't want to dominate the Q&A. We do have folks who wish for stimulant safe supply, and we do have some folks who are getting stimulant safe supply, although sometimes I feel like it's a bit of a misnomer because we just don't have access to the kind of stimulants that produce or approximate the effects that people are looking for. So we do have things like Ritalin, other sort of psychostimulants, but they're not ones that really produce the same euphoric effects that people get from an illicit supply.
There's a couple of comments and questions in the Q&A related to housing, and I really appreciated your slides that you had and the what you shared about housing for safe people who are in safer supply in your program. do you want to comment at all a little further about that relationship between safer supply, housing, stability and wellness? The comments here are just about how unbelievably difficult and dire the housing situation is in Toronto. How it's a critical element for health.
Yeah, it's pretty bad here, and I think like it certainly, I think, gets in the way of just kind of enhancing that engagement for a lot of our folks who are unhoused. And I think there's like obviously because there's a huge distrust already with a lot of systems, and like we're working from a system that's kind of we're in the healthcare, and we're trying to increase that relationship with a lot of our folks. But a lot of our housing resources are getting smaller. Affordability is almost non-existent. And a lot of housing workers that I collaborate with, like a lot of them are overworked as well, and caseloads are massive, and it's just, and there's not a lot of support for that. So it's getting harder and harder from all angles. And obviously it's the folks that we're supporting that are impacted the most. And in some senses, like a housing first model works, in some cases it doesn't. So I think it's important to be mindful of that. And it's not a one size fits all kind of situation with housing. So yeah, it's major challenges with that for sure.
Thanks, Paul. I think we're also seeing too that for some people, the prescription can be such a stabilizing factor in their lives, with or without housing. And then for some people, without housing, the prescription is just inaccessible. Like if you're in a shelter one day in East Toronto, and then the next day you're transferred to Northwest Toronto, and your pharmacy is down there, then you lose touch with the program. Like, so yeah, how well the two go together to support stability and well-being is pretty important. A couple of capacity for the program now. What's the program capacity, and do you want to talk a little bit about your catchment area or how you determine that? And what are the possibilities around growing?
Mish, would you like to respond to this? Or I mean, I can, or you can.
Sure. There's always been the question from the beginning of these programs over the last couple of years about like, what does sort of ultimate capacity look like? And that's really difficult to tell because things are very up and down, and we'll take sort of new cohorts of clients, and it can take different amounts of times before people are sort of stabilized enough to give us breathing room to take more folks. But we do have more room to take people at this point, although I can't give a final number. And certainly the demand far outweighs what we can offer, unfortunately. We recently took about 20 clients, and at the same time we got, I think, 56 applications to be a part of the program. So we're definitely, unfortunately, turning away more people than we can take in because our funding and capacity is limited.
Yeah. Are clients on OAT or using a backbone in conjunction with Dilaudid? Can you speak to that as well, Ashley or Mish?
Yeah, the majority of folks in our program are on a backbone, whether that's methadone or Cadian. The reason being that, like people expressed in the evaluation, the Dilaudid is often not enough to be reaching people's needs alone. So we do have the long-acting morphine or methadone to help people with reducing dope sickness, with reducing cravings, and also that if you're on a long-acting form of, for example, morphine, that when you are using the Dilaudid, that hopefully you'll have a bit more of an effect out of what you're taking.
Thanks, Mish. I also just want to comment that during the course of this webinar, in the chats and the Q&A, private messages to myself, probably others on the panel, we've been getting like, how do we get on the program, and like how long, and I need this program, and I'll let you speak to the like how do people get on the program, but just want to acknowledge just what the demand for these programs is, and how frustrating and how hard it is to say, the capacity is so limited right now.
Yeah, so in terms of like just how our intake process works, Mish referred to this, but when there is assessed capacity, and that, as Mish mentioned, has to do with a whole bunch of different factors, we will publicly open the program for referral applications. People can self-refer, or they can be referred by a trusted person with consent. And we open the referrals for 2 weeks at a time, and then afterwards go through a review process. So that has happened 3 times in the last year, for example.
Were there any unintended consequences or surprises that you came across in your evaluation?
Quite honestly,
Unintended consequences can be positive or negative.
oh, well,
Putting
I
out
mean,
there.
that's a good reminder. Yeah, I
Yeah.
do think that, as you know, as everyone knows, we started with a more circumscribed set of outcomes that we were looking at in terms of these primary outcomes around overdose, risk of death, harms from criminalized activities, things like that. And so all of that other stuff that we learned about in terms of people, for example, wanting work and volunteer opportunities because there's space in their life, because, they have like knowledge and energy to share, and that's freed up for them, whether it's because it's freed up their time, whether it's because relationships are better for people, things like that. I think that a lot of the quality of life outcomes were not necessarily things that the program explicitly said, okay, this is what we're aiming to do, but they've absolutely come through. In terms of negative unintended consequences, quite honestly, I'm not thinking of anything off the top of my head. I don't know whether Paul, Ashley, Mish, you guys have thoughts about other things that came through in the evaluation. Not consequences so much as just like, areas of need that the program's not responding to. I think that's, what we highlighted in terms of the client identified needs.
Thanks, Kate. Ashley, Jillian's asking, I really appreciate your point about transitions into hospital and how difficult this can be for people on safer supply. Kate mentioned this in the report too. Do you think that the work needs to be done on the side of the safer supply programs or on the side of hospitals? What would be helpful?
Hospitals definitely need help. Definitely hospitals. But I think both could work together more effectively. But like, I don't know, hospitals or something else when you're on even methadone. So yeah, I think it's the whole system that needs help. Yeah, I think if we worked better together, also if like hospitals listened to the people who were in front of them a little bit more, I think that would help. But yeah, I think people could do better at working together better all around.
Yeah, more collaboration across providers in general.
Yeah, like it's really nice when all your care providers can all be communicating like all together and have like pretty fluid access to each other. That's worked well for me. So
I appreciate that someone just added in a question, extending this question about hospitals and primary care and safer supply and harm reduction to also jails, and recognizing that transitions into and out of jail are also really, really difficult and potentially lethal moments. Can you speak to what people's experience is like from the community, from the Safer Supply program, moving in and out of custody?
Extremely challenging. Even like Ashley was saying about hospitals, even getting out continued in the carceral system, it feels near impossible. We even have someone who anticipated being incarcerated, and we transitioned all of their dilaudid dose into Cadian so that they were just on Cadian and methadone, because we knew likely the dilaudid wouldn't be supported. And when they were incarcerated, they put them on a starting dose of methadone. And just eliminated 15 milligrams of methadone and 900 milligrams of Cadian, even though there's full documentation of this person receiving this medication. So unfortunately now with the illicit supply, what we're also seeing is people who stop using fentanyl abruptly can be at risk of seizures and benzodiazepine withdrawal. And that's certainly not being addressed. And we've had folks have seizures upon incarceration. And then trying to reach anyone in the jails and prisons, trying to get records from jails and prisons, it feels like a brick wall, to be honest.
For sure.
Yeah, to piggyback on that point Mish just raised, I think like the communication just needs to be stronger in general. There's always like this air of inaccessibility when somebody is incarcerated, or even when they go to the hospital. Like, who do I, for me as a primary support, like who do I get in touch with? Who can I talk to? There's always just like this kind of nameless unknown when our folks go into those systems. And I think there just needs to be more transparency in that collaboration, because it's supposed to be a collaboration. And so, that need is neglected because there is no communication.
Thanks. It's a very difficult situation. It feels like it doesn't need to be, but the complexity is definitely there. Someone's asking, Angela is referring to the counselor in the program, and given the success of the counseling support, is this something that future funding would be considered for adding more counselors?
I mean, I think that the hope would always be that, the Safer Supply program could grow in some of these ways, but before that can ever happen, we need to have sustained core, guaranteed funding for our existing services. So certainly, I think, we would love, I can't speak for everybody here, but I think it would be great to provide more care, more roles, more staff roles for people. But first step is to secure our program.
Yeah, for sure. What age range do you work with? And more specifically, do you work with youth? This person's asking because they're acknowledging that while it can be controversial, there's a real need to meet the needs of youth, as youth hospitalizations are on the increase from toxic drug poisonings.
Yeah, we don't have like a lower limit of age. There is no age of consent for medical care in Ontario. So we have recently also began prioritizing youth within our referral and intake process, recognizing this need.
And let me just go through, there's a couple questions above that I haven't addressed. One question is about contacting you to learn more about the evaluation and the project and safer supply initiatives. We'll put our contact with the contact info is on the website. You can check out the website. I see that Mish posted in the chat a link to the website page, Parkdale Queen West page, including about when referrals are open and getting on the mailing list. So that's one place you can use to get contact information. You can also contact us at the National Safer Supply Community Practice, so we can talk to you about other programs as well and share other information as well. So there's those two ways of getting in touch with folks. And then there's another question here about diversion and how diversion is mitigated. The risk of diversion is mitigated.
Mish, do you want to speak to that? As I know you're on the hot seat a lot, but because you have the clinical experience.
All good. In terms of diversion, we do urine drug testing periodically, at least to confirm that people are taking their medications. I mean, diversion is always the hot topic. There's a lot to say about it. There's a lot to say about the positives and negatives. It's a really complex issue. I would almost just like to defer to the community of practice document around diversion that talks about sort of the nuances and complexities of this issue. Beyond that, we do try and talk with our clients if we know or suspect diversion to approach from a non-punitive perspective. And we know that diversion occurs for a variety of reasons, and sometimes that's because people aren't getting their needs met otherwise, and so that diversion doesn't have to occur as often.
Thanks, Mission. Thanks for the plug for the reframing diversion document as well. People can see that, and also just giving people a heads up that we are having a webinar at the end of June that will address research around this topic and to launch, to reintroduce this document as well to the world. And I think we'll end there. I really want to thank you all, and it was really great hearing about the findings of this project evaluation and hear what's happening at Parkdale Queen West. I think it's been a real journey. A lot of the safer supply work came from people who were working in Toronto from Parkdale Queen West, and so it's been great to see that evolve and come to where it is today. And I'm excited to see where it goes. I'm just going to share my screen to do just a last plug. People can have the access to our website and encourage you to go there. You can find the recording of this webinar and the report from the Parkdale Queen West program evaluation at our website, and also at Parkdale Queen West's website. Paul, Ashley, Kate, and Mish, thank you all so much for being here today to present the findings. And a big thanks to all of the attendees who came today as well to learn and hear about the program and about safer supply. I think it's really important that we share this knowledge and keep learning and finding out more and more about how safer supply is supporting folks in our communities. Yeah. Thank you all very much.
Thank you so much, everyone.